I'm going to record to the iCloud. Don't know what's going to happen, but we'll see. All right, Jared, briefly, do you want to give a rundown of kind of where you're at currently, what you're doing, and then we can start the party?
Yeah, that sounds good. So for those of you who don't know me, I'm Jarod Hall. I'm a physical therapist in Fort Worth, Texas. I'm about 6.5 years out of school, and have in that time kind of gotten back involved with teaching in PT school as well. So I do a little bit at the UNT Health Science Center here in Fort Worth, and a little bit at with Baylor DPT through my buddy Rich Severin. Got me hooked up with the health promotions program there. And on the side, with my partner Mark Cargilla, we run Modern Pain Care, which is just a platform that really pushes a lot of continuing education, trying to, get people up to speed on what it is that we know about pain right now, and, gradually try to evolve with that as we learn more. And, I've recently just taken over kind of like a management type position. So I'm over multiple clinicians at multiple clinics, and I'm still in clinic a few half days a week, but I've stepped away from full-time clinical practice just to do a lot of mentorship and a lot of leadership and that sort of stuff. So that's kind of where I'm at right now. Still keeping my toes in the water of clinical practice, but doing a ton of mentorship and education. And I want to thank Chris for setting this up and asking me to come on. I'm not super excited about the fact that I'm following Chad Cook. That's not cool. That's never cool to do. It's like the bar is probably set pretty high, but I know that I've done a lot of these research reviews and that sort of thing. And I was telling Chris before everybody jumped on that, no offense to you guys, but most people don't read the actual article before you jump on one of these things. So what I want this to do is be something where anybody could come through after this, never having read the article, and get a really good idea of how the research article was designed, what the findings were. And, I went through and I kind of set up a PowerPoint style presentation. That'll probably take 20 minutes or so to go through, just to really break down that article and look at it through the eyes that I look at it through, and ideally encourage you to go back and read that study with a fine-tooth comb yourself and reflect on it. So I want to go through that article. There's going to be some topics that come up that I would really like to discuss afterwards, because I think this particular article brings up some really good topics that we can talk about, as far as the mechanisms of manual therapy, as far as the concept of pragmatically applied, research designs with manual therapy, the concept of clinical and personal equipoise, and a lot of things that I think are really important and pertinent to the way that we should think about how the interventions that we're choosing to use might work or might have an impact on the patient, the person that we're working with. Man, there's a lot of people popping up in here.
That sounds perfect.
So I guess I'll go ahead and share my screen, and we'll go through this. We'll run through that article. And there's a couple of places in there where I like bolded it. I was like, hey, let's come back and talk about this. And I've got a terrible short-term memory, so I'm going to need you guys to remember that for me, so we can blast some questions and have some good discussion when we circle back around to the end. All right. You guys seeing that? Thumbs up if you are. Cool. Okay, so this is a pretty cool study that I felt like was the direction that a lot of manual therapy research studies should go. It was published 2 years ago in JOSPT. I wanted to choose something from a journal that probably most of the people here are super familiar with. It's a high impact journal. It's one of our more respected journals in the PT world, and especially in the orthopedic world. So I felt like it had good credibility. It was in a familiar journal. You would probably be able to access this article pretty easily afterwards from one of your colleagues, and not have to, pirate any any research or anything like that. So this was an article by Griswold and Company. You see Josh Cleland on there, who's a big time researcher whose name's been associated with the EIM group through the years. So pragmatically applied cervical and thoracic non-thrust manipulation versus thrust manipulation for patients with mechanical neck pain, a multi-center randomized control trial. So here's the AMA reference, just in case you guys want to have that, if you're going to cite it, if you're going to look it up. So what was the background? What was the objective? Why did the authors design this study? So we all know that orthopedic manual therapy, or OMT, includes various types of thrust and non-thrust interventions, and non-thrust interventions are defined as repetitive, rhythmic, passive, oscillatory movements with a small or large amplitude. So if you think back to like your Maitland grades, right, your grade 1s, grade 2s, grade 3s, grade 4 mobilizations, where you're trying to direct some sort of force at a target joint or whatever it may be. And then the thrust manipulation would just be your high velocity, low amplitude thrust. And there's different thought processes on this as far as osteopathic type of approach, or more of a general manipulation type of approach, or maybe more of your chiropractic type of approach, right? There's all of these different sub approaches within that, but this is just going to be non-thrust versus thrust. So mobilizations versus manipulations. So we've seen all of the research throughout the decades show that it seems like doing mobilizations or non-thrust types of manual therapy seem to help people with their pain, at least in the short term. At the same time, we've seen that doing thrust-based manipulations, high velocity, low amplitude type of manual therapies seem to help people with their pain, at least in the short term, right? And there's a lot of different theories on the physiological effects of that and why that might happen, but these actually haven't been compared against each other in a pragmatically designed study. So they've been compared against each other in a really prescriptive type of design, where one group will be randomized into, you're going to get 30 seconds of this exact style of mobilization, and the other group is going to get, a hyper specific single thrust manipulation to a specific segment of, the cervical or lumbar spine. And they haven't been set up in a pragmatic design. And we'll talk a little bit more about what that means to be pragmatic. But when you look at all of the mobilization research and all of the manipulation research, and you look at actual outcomes on global rating of changes, you look at outcomes on neck disability indexes, you look at outcomes on NRPSs, you see about the same level of change usually. On average, you see about a 2 out of 10 change, 2 to 3 out of 10 change on the NRPS. And we know that, what's most clinically meaningful is kind of targeting at least 1.5 to 1.9 on, points of change on that NRPS. The only studies, and I put some asterisks by the people that I referenced, right? There's not been any superiority other than there is one particular research group led by James Dunning, who has repeatedly published trials that support high velocity, low amplitude thrusts over non-thrust type of interventions. And I think that that's one of those things that I want to circle back around to and talk about at the end of this. I think we can have some good discussion on that, especially when we get to the section about clinical and personal equipoise. So we've seen by the work of Joel Bialowski and a lot of others that there are multiple levels at which manual therapies seem to work, just manual therapies in general. They might cause some changes locally or segmentally at the tissues. They might cause some changes at the spinal cord. They might cause some changes at the brainstem. They might cause some supraspinal changes, and they might have some form of meaning response or placebo effect, right? So there's 5 different, theoretical pathways or mechanisms through which manual therapy might influence a person's outcomes. And if you guys haven't read Bialowski's study, in 2008, The Mechanisms of Manual Therapy. Strong recommendation to start Googling or PubMed searching Joel Bialowski. So he's got some great stuff on manual therapy. And a few of those have been published recently, which are really thought-provoking reads. So due to the temporary nature of for manual therapy interventions, most of our clinical practice guidelines say don't use manual therapy in isolation, right? Pair it with exercise, pair it with education, pair it with patient-led goal setting, pair it with all of these other things. So I think that a multimodal approach to care is hard to argue against, but I think that we can really get into the nitty-gritty a little bit later, talking about how much value does manual therapy provide, and is it the manual therapy itself, or is it more that a lot of research studies are designed in A versus A plus B trials, where some people in one group just get exercise and people in the other group get exercise and manual therapy. So they're getting two treatments, they're getting more treatment, and you tend to have additive effects, additive non-specific effects of more treatment versus less treatment. So I think that's some really interesting stuff that we could probably talk about a little bit later. So the reason that I liked this study so much is because it tried to bring thrust manipulation or thrust manual therapy and non-thrust manual therapy into the real world, right? And that's what pragmatically design means. That means that we're going to let the clinicians actually decide which technique am I going to use? Which non-thrust technique am I going to use? Am I going to do a central PA? Am I going to do a unilateral PA? Am I going to do a rotational oscillatory mobilization? You can do whatever you want as long as it's non-thrust, and you can do it for 30 seconds, or you can do it for 3 minutes, or you can do it for 5 minutes. It is completely up to the clinician based on the feedback that they're getting from the patient, and based on that clinician's personal experience and their expertise and all of this sort of stuff. So I like that it actually mimics what a clinician might do in the clinic versus having them do a very cut and dry prescriptive intervention, right? And they could decide, hey, what segmental level do I want to do? Do I think that this person has an issue at C2, C3, and I want to apply my manual therapy to C2, C3, whereas in a prescriptive trial, I might have to apply my manual therapy to, what I think is C6, C7, even though I think that their problem is at C2, C3. So this pragmatic design actually allows the clinician to use a lot of critical thinking and clinical reasoning to determine what type of manual approach that they use and for how long they use it and how aggressive they use it or how gentle they are. It brings patient feedback into the mix a whole lot more, right? So it really frees up their clinical decision-making process. The only limiter is one patient will have to get non-thrust and one patient will have to get thrust. So you don't get to choose if they're in thrust or non-thrust. That is what's randomized. But within those categories, you're allowed to approach that however you see fit, right? So the purpose of the study was to compare the effectiveness of pragmatically applied thrust versus non-thrust manipulation, targeting whatever the symptomatic level was, which I think is another important distinction, because some research trials that are, prescriptive don't necessarily always target the symptomatic level or what the clinician believes to be the symptomatic level. It's just saying, hey, does a C4, C5, or does a mid-cervical manipulation or mobilization improve neck pain? When you might think that, well, maybe it's a little bit higher up in the neck, or maybe it's a little bit lower down in the neck. I have to do what the parameters of this study say. So I think that that's another aspect of this study that made it more real life. It made it a little bit better of a study to get some takeaways from. So what did they do? It was a multi-center RCT, which I think provides a lot of value as well, because you get different clinicians within different clinic environments, within different cultures actually involved in the research study. So you're seeing a little bit wider range of what this might actually look like, rather than doing a randomized control trial out of the same clinic that has the same environment with the same clinician, because that particular clinic might carry a lot of environmental factors or contextual factors that have an influence on the outcomes. So while it's controlled better, it's not as real life. So I like that this was a multi-center randomized control trial. So it involved 7 different clinics, and it was over the course of 12 months, and it spanned in multiple different states: Ohio, Pennsylvania, Texas, South Carolina, Oregon, and Alaska. So you could get some cultural and regional differences in the expectations that patients have for manual therapy, or the expectation that patients have for physical therapy in general. You might get different demographics, higher or lower socioeconomic status across those different states. So I think that while it's less controlled, it's more real life, which is really what we want. We want research that reflects what our clinical practice is actually going to look like on a day-to-day basis. So patients were eligible if they had mechanical neck pain. They were between the ages of 18 and 70, had at least a 20 on the NDI, and had at least a 2 out of 10 pain over the past 24 hours. So pretty broad range, right? You have some neck pain. It needs to be at least moderate neck pain, but there's a wide range of, possibilities from severe neck pain to, just above mild neck pain to pretty moderate neck pain. All people were excluded if they had any contraindications to OMT, maybe a recent surgery or something like that, or maybe a significant upper cervical vascular pathology. They had any signs of nerve root compression. If they were in the process of seeking litigation, like maybe they had been in a car wreck, or they were getting treated under a letter of protection or something like that, or if they were receiving other forms of non-surgical care, which I think is important, because there's oftentimes thought to be some issues with certain research designs, because patients are also going and getting treatment other places. And if people do get better, you don't know if it's because of what you did in the research study, or if it's because of what they did at a different clinic or a different healthcare provider somewhere else. So just to give you a brief overview, they assessed 150 patients. They excluded 47. They ended up with 103, and they used a computer design that pulled up a random number that would determine whether or not the patients were allocated to non-thrust manipulation or thrust manipulation. And you had 55 in the non-thrust and 48 people in the thrust manipulation. Both groups just lost a couple of people, so it was pretty equal, and the final analyzed amount was 55 for non-thrust and 48 for thrust. So had a pretty good rate of completion of the study, which we always like to see. You always worry if you see a bunch of people drop out of a study, like, why did they drop out? Did they drop out because they weren't getting better? Did they drop out because the treatment was making them worse? Did they drop out because they didn't perceive any value? So this is actually really nice to see basically everybody that started the study finished the study. That means that they felt like they were probably getting some decent treatment. They didn't get dramatically worse or anything like that. So that's a good thing to see. It's also a good thing to think about for your adherence rates to treatment in the outpatient physical therapy world. If you're doing some decent evidence-based care, seems like people want to continue coming because maybe they are finding some value in that. So if we look at the actual clinicians, there were 10 different clinicians, and they had an average of 13 and a half years of experience. So these are fairly experienced clinicians. So nobody can really make the argument that, well, they just, they hadn't had enough experience under their belt. They weren't great at utilizing, manual therapy approaches. On average, these guys are all highly trained. These guys and gals were all highly trained, and they had a pretty significant amount of experience under their belt. All of the clinicians were deemed advanced OMT practitioners through the American Academy of Orthopedic Manual Physical Therapists. And so that means that they either had their COMT, or they had done a residency, they had done some sort of fellowship training. So the study, one of my favorite things about it is it actually looked at the concept of equipoise. So a lack of clinical equipoise in trials may bias interventions or data collection processes, and this could obscure the findings. So they evaluated the authors on two different components of Equipoise. First, they looked at global belief of overall technique effectiveness. So what that means is that they surveyed all of the treating clinicians in the study and asked them, what's your bias? Do you think that manipulation is better? Do you think that thrust manipulation is better? Or do you think that non-thrust manipulation is better? So before they even let them touch a single patient, they asked them, what's your bias? What are you in favor of? And then following the examination of each patient, they asked the clinician again, hey, which treatment do you think would be better for this particular patient? Do you think thrust manipulation would be better, or do you think non-thrust manipulation would be better? So a clinician's bias could play a role here. If the person was really an older patient, they might say, oh, you know, I think mobilization is a better treatment approach for them versus a thrust manipulation. Or if they felt like that person was hypermobile or whatever it might be, they might say, oh, I think, you know, mobilization might be better for them rather than a thrust manipulation. So they allowed the clinician to report what they thought was going to be the better treatment for that patient. So if you guys are wondering what equipoise is, so equipoise is when investigators hold no bias towards one intervention over another. And it's honestly a really necessary ethical principle in clinical research. So that means if you design a study and all of the providing clinicians, the providers in that study believe that thrust manipulation is head and shoulders above non-thrust manipulation, and then you're comparing whether or not patients get better with thrust manipulation or non-thrust manipulation, it could very easily skew the results that you get. It could skew your outcomes because you have a bunch of clinicians treating patients with an intervention that they don't believe in. So when they draw the card for thrust manipulation, they go through their entire clinical routine and they put on their show and they talk about how great manipulation is, and they get pumped up because they get to do the treatment that they think is going to be effective. And then when they draw the non-thrust card or the mobilization card, they walk over to the patient and they say, oh, well, this is dumb. This is stupid. I don't really want to do mobilization. This isn't going to help you because I believe in thrust manipulation, right? So those things, even if they're subtle, do come through, and they play a role in outcomes, because we've seen multiple times in countless studies that the way that a clinician interacts with a patient and the beliefs that the patient has about a treatment and the beliefs that the clinician has about a treatment actually directly affects the measurable outcomes. And, you know, that all circles into what we would call meaning response. And we'll talk about that a little bit later as well. I think that that's going to be a really important concept to cover. So the way that they measured the treating therapist's equipoise was on a -2 to +2 scale. And what they did was, on -2 was highly in favor of non-thrust manual therapy, and +2 was highly in favor of thrust manual therapy. And a 0 being in the middle on that spectrum indicated that you were pretty equivalent. You thought that non-thrust or thrust could be good, and you didn't really have a preference, right? So way over -2, non-thrust, way over +2 was thrust. So this is actually what we saw on the measurement of equipoise for the treating clinicians. And you can see all of their credentials, right? You've got a bunch of COMTs up there. You've got a bunch of OCSs. You've got some PhDs. You've got a couple of people who were in fellowship. And overall, there were 4 out of 10 clinicians that were in favor of thrust manipulation. 2 out of 10 clinicians were in favor of non-thrust manipulation, and 4 out of 10 were pretty equivalent in how they viewed things, right? So I'll go ahead and let you guys know my bias. I don't see a big difference between thrust and non-thrust manual therapy. So I would be somebody, I think that they work through the same exact mechanisms, and I think that it's more about patient preference or patient expectation. So I would be somebody that would fall on the 0. I would fall more towards like, yeah, you know, whatever, they're about the same. I think that they're both, you know, good, equally good or equally bad, right? But there were 4 out of 10 that were in favor of thrust, 2 out of 10 that were in favor of non-thrust. And if you look at the points, right, there was actually 6 points for thrust manipulation, 3 points for non-thrust manipulation. So you had essentially a stronger overall effect for thrust manipulation on the measurements of clinical equipoise. So on patient examination, they examined the deep neck flexors with your normal deep neck flexor endurance test, where you have somebody do a little chin tuck and raise up their head 2 inches off the table and see how long they can hold it. And they did passive accessory intervertebral motion testing, which that should be another discussion that we have at the end, the reliability and the validity of passive accessory intervertebral motion assessment. However, what they did was they looked at the PAIVMs specifically for pain provocation. And I think that that added a little bit more validity to the study, because pain provocation is regularly repeatable and it's reliable. Whereas motion palpation from an examiner standpoint has shown to be highly unreliable. So focusing on that subjective feedback from the patient actually improved the metrics with which they designed the study. So they were trying to find the most involved segment of the cervical and the thoracic spine. So essentially they were just trying to see, where does it hurt most if I give you pressure here? If I move these joints, does it hurt here or does it hurt somewhere else? So the spinal segment targeted for both thrust and non-thrust was based on the reproduction of the concordant sign, or that's, you know, in the Maitland model of manual therapy approach, that's the specific level or the area that reproduces whatever the patient's symptoms are, whatever the patient's pain report is. So like we already talked about, although they lack specificity, they don't have good reliability or validity in terms of segmental movement of the spine, pain provocation is actually pretty good. When you poke on an area and the patient says, yes, that's my pain, that's why I'm here to see you, that's actually a pretty good indicator that you're at least in the right area for where their tissues are the most sensitive. And I think that we can, again, have a pretty good conversation on tissue sensitivity and referred hyperalgesia and referred pain and all that sort of stuff that might make this a little bit more muddy and a little bit less clear than we would like it to be. So what outcome measures did they use? The primary outcome measure was the Neck Disability Index. So as you know, the NDI is 0 to 50 points or 0 to 100% scale. And a higher score equals worse disability. And the minimally clinically important difference is 7.5 points or 15%. So you're looking for at least a 7.5 point change or at least a 15% change on this metric to know that you actually made an important difference on their life. Then secondary measures were the patient-specific functional scale. The NRPS averaged over the last 24 hours, and the global rating of change scale, which is a 15-point scale ranging from -7 up to +7. And it essentially indicates whether a patient believes that they got better or not. If they say a -5, that means, you know, I got a lot worse over the course of this study. If they say a 0, they say, well, you know, I stayed about the same. I didn't get any better. I didn't get any worse. If they say a +5, that's I got way better. Like I am definitely dramatically better than I was when I started this whole treatment process. So if you look at the actual interventions in the thrust manipulation group, the treating clinician performed a high velocity, low amplitude thrust to the most symptomatic segment of the cervical and thoracic spines. And I just put in the question, are we that specific? Are we good enough to target a single symptomatic level? Are we good enough to target a specific symptomatic side? And I think that there's some research that would say that we could probably get the area that we're going after, but is that the only area that we're getting? And can we be completely confident that we got exactly what we were trying to get? And I think that opens the door for a pretty interesting discussion on the whole topic of specificity of applied manual therapy. So the type, direction, and number of thrusts were completely up to the discretion of the clinician. So again, that's pragmatic. So if they wanted to do 3 thrust manipulations. If they wanted to do more of a side bending technique, or if they wanted to do a prone technique, or if they wanted to do more of a rotational or more of a distraction type technique, whatever they felt like was the best, they could choose, and they could do it as much or as little as they want, whatever they thought would be the appropriate treatment for that patient. So that's exactly what you would do in clinic. You would decide, oh, I think that this person's going to benefit from a right rotational manipulation, and I'm going to try that 2 or 3 times, and I'm going to do it at this level and that level. So it really let the clinician do exactly what they would do for a regular patient in their clinic. So the treating clinician recorded those specific parameters for the first couple of sessions just to say, hey, this is what I'm doing. And then they didn't have to necessarily record exactly what they did after that, but they were going to continue on with approximately the same manipulation type of approach. In the non-thrust, same thing, but they received graded oscillatory techniques to both the cervical and the thoracic spine. So again, that could be prone PAs, that could be unilateral PAs, that could be rotational mobilizations, that could be grade 1s, that could be grade 5s, whatever the clinician thought was the best, and whatever the patient, if that clinician was treating in a way that's normal for them in clinic, I'm sure they were getting patient feedback. Hey, how is this pressure? How is that pressure? How is this speed? What does that feel like? Does it feel like I'm in the right area? So they're getting real life feedback rather than being in the highly restricted prescription type of manual therapy approach. So all of the dosage was up to the decision of the clinician. And the same thing, they recorded what they did for the first couple of sessions, and then they pretty much continued on with approximately the same approach. Other interventions that were given to the patient were a home exercise program that included range of motion exercises and deep neck flexor exercises, or deep cervical flexor exercises. All of the AROM exercises were performed 2 sets of 10 twice daily. So they said, hey, work on in-range rotation, do your snags or whatever it is, do your repeated movements, 2 sets of 10 twice a day, every day, and go ahead and start working on your deep neck flexor endurance. Do your chin tucks, do your retractions with a lift and hold it for as long as you can hold it. And that was at the discretion of the clinician based on the patient's capability of doing those. So lastly, both groups received postural education, advice to stay active, and encouragement to participate in their normal activities. So that's basically right out of our clinical practice guidelines, right? They said, hey, try to move or position yourself in a posture that feels good for you. Try to not be slumpy or whatever. I don't know the words that they used. I'm just guessing of what they told the patient. Stay active. Don't let this debilitate you. Motion is lotion. Exercise is good. So on and so forth. I'm sure that they told these patients this, but they also said, continue to participate in your normal daily activity. So that's right out of our clinical practice guidelines. No other interventions were used. So we had active range of motion, deep neck flexor exercise, postural education, and either thrust or non-thrust manipulation, manual therapy at the discretion of the clinician. So one of the things I always like to look at is side effects or adverse events, just because if you're going to do a risk-benefit analysis on any sort of intervention, you need to know, is the benefit that this intervention provides actually worth the risk that you're taking for providing it? There were 26 of the 103 people that reported at least one minor side effect, and it was pretty equal. There were, 13 in the non-thrust and 13 in the thrust. So pretty equal. Doesn't show that one had way more adverse events than the other. And the most commonly reported side effects were a little bit of pain, headache, some dizziness, some radiating symptoms, muscle stiffness and soreness, and muscle spasms. And the most common side effect was temporary increase in pain or perceived stiffness, which I think is interesting because manual therapy, by and large part, is promoted under the thought process of reducing stiffness and reducing pain. Well, the most common side effect was increase in pain and increase in stiffness, which I think we should take pause and think about a little bit and ask ourselves the question, is manual therapy appropriate for everybody? Or do I need to think a little bit more closely about what this manual therapy is potentially doing to their nervous system, and what that person's expectations of that manual therapy is, and that sort of thing. So just to get some baseline characteristics of the patients, there were quite a bit more females than males. So you see, in the non-thrust 41 to 14, and in the thrust 35 to 13. And I don't know why this is, but it's been my personal experience that women are a little bit more likely to actually seek care than men for things like this. So it's not to say that women have more neck pain than men. It's just to say that a lot of men are too stubborn to maybe actually go out and get appropriate care. Ages were about the same side to side, heights, weights, body mass, everything was about the same side to side, symptom duration. The only thing that was a little bit different was the non-thrust group had a little bit higher, not clinically significant, but getting close to statistical significant difference in baseline pain, a 5 versus a 4.3. This is their baseline NDI scores, essentially exactly the same. PS, FS, essentially exactly the same. NPRS, the same. Deep neck flexors, the same. So we did a really good job of randomizing these and coming up with a relatively equal group side to side. So what were the results? So the results of the two-way mixed ANCOVA revealed no significant interaction effects for time and group on the NDI, the patient-specific functional scale, the average NPRS, or deep neck flexor training while controlling for clinical equipoise. So significant main effects for global equipoise were observed for the NDI, the patient-specific functional scale, and the NPRS. So what this means is that there was an overall effect in favor specifically of thrust manipulation, because it followed the fact that globally the equipoise for the group of clinicians slanted a little bit towards thrust manipulation. So significant main effects were also noted on the individual patient equipoise for the NPS, the PSFS, and the NPRS. So this effect suggests that patients treated by clinicians with a preference towards thrust manipulation for that patient had a little bit better outcomes, which it wasn't dramatic because both groups got a lot better, but there was a slight lean towards thrust manipulation, which is an interesting thing to talk about. So if we look at the outcomes, global rating of change, essentially the same. Number of visits, the thrust manipulation group averaged slightly more visits, and the duration of care, the non-thrust group averaged slightly more days of care. But again, these were non-significant. They're very, very, very similar. If we look at baseline NDI scores, you essentially only see one line. So the blue line is non-thrust, the yellow line is thrust, and they're layered directly on top of each other. They even have the same confidence intervals. They have the same level of variation between baseline, visit to, and discharge. If we look at the 24-hour NPRS, we saw that the thrust manipulation started just a little bit lower, and the non-thrust started just a little bit higher. And some people would argue if you start with a higher level of pain, you have a greater likelihood of reducing your pain more because there's more to reduce. I think that might be a flawed rationale, but I've seen that argument made before. But what you see is by visit 2, they have completely equalized with each other. And then by discharge, again, those lines are layered 100% right over the top of each other. And you see the same exact outcomes for the thrust and the non-thrust. So what do our conclusions say? To quote the authors directly, the findings from this RCT suggest that both non-thrust and thrust manipulation produce comparable outcomes in pain, disability, motor performance for patients with mechanical neck pain when applied in a pragmatic fashion. Patients' perceived level of change, the number of visits, and the duration of care were similar between groups. Other takeaways. Previous research has demonstrated patient preferences and expectations of specific intervention, manual handling confidence of the treating clinician, and patient's perception of a clinician's expertise all play a role in treatment outcomes. So that's That's what we would call our meaning response. You know, we've traditionally called this placebo effect, but I think that placebo effect sells short all of the complexity that's actually going on in the clinical encounter, and where a lot of the actual change in, you know, the actual measurement of the placebo effect comes from. That placebo effect that you see that's this big, you know, it might be this much patient expectation, this much clinician theatrics, this much, you know, a nice calm environment. It could be all sorts of stuff that actually goes into that placebo effect. And really, it's how much meaning does that treatment have for the patient that's receiving the treatment. So given this information, clinicians should defer to utilizing interventions in which they are personally most comfortable, and or those that the patient has a greater preference for, with the caveat that those treatments come with no harm and they're accompanied by a helpful narrative. So if a patient tells me, well, I really believe that bloodletting is going to help me get better from my neck pain, I am not going to perform bloodletting, A, because I know that it's not a viable treatment, and B, because it very likely could cause harm, right? It could cause infection. It could cause excessive loss of blood. It could cause multiple other things. So that risk-benefit analysis is not in favor. And that is when it's not okay to just go with whatever the patient perceives as the best, right? So if a patient tells me, yeah, I really want you to needle me super aggressively, and I think that that's going to help me, but they want me to do dry needling in an area that's got peripheral and central sensitivity, and me doing that needling actually increases, you know, the level of sensitivity that they have, that's probably not a great treatment approach. Just because the patient wants it doesn't mean that it is something that I should automatically cave in and give them or provide to them. And I think that this is a very, very difficult discussion and topic that I don't have the answers to. And it's a discussion that's constantly going on about, you know, how much do we meet a patient where they're at, or with, you know, with whatever their preferences are, versus what the literature is actually saying about that treatment that they have a preference for. So it's not uncommon to see people seek out treatments that actually make them worse, even though they perceive or they expect them to make them better. This happens regularly, and it's how a lot of the, you know, alternative medicine world survives, because the patient is seeking something, they're providing it, even though the patient isn't getting any better. So what were the limitations of this study? So it was a sample of convenience, so that was a little bit less sophisticated than a more you know, specific type of randomization where patients were sought out at different clinical centers, or where they were recruited. It was just a sample of convenience in the clinics that they had of the patients that walked through the door. There wasn't a control group used, and there wasn't an exercise only group, and there wasn't a placebo group. So a lot of people get a placebo group and a control group actually confused. A control group is a group that literally nothing was done on. It's just wait and see. You take a sample of people that have neck pain and you don't provide them any treatment, right? So that's a true control group. And that allows you to see what natural history does. That allows you to see what regression to the mean does. That allows you to see what just time is going to do to these people's neck pain. Well, an exercise only group would have the problem of an A versus A plus B design, but it would let you see the difference between those. It would let you measure how much more value does that additive treatment provide. Is it clinically significant? Is it statistically significant? Or is it non-significant at all? And then of course, a placebo group. And placebo manual therapy is something that is very, very, very difficult to do, because at all times we have to touch the person to provide manual therapy. And we can't just tell them that they didn't get manual therapy, and we can't just, you know, gently rub their skin in a, you know, strange, you know, type of intervention that they've never had before as a placebo, because they'll quickly catch on to the fact that they're getting a placebo treatment. So it's very, very difficult to design placebo-controlled manual therapy trials, but there are some really interesting ways to do that. It's difficult, and it's not very common. So as with all OMT trials comparing therapeutic interventions, the treating clinicians and patients could not be blinded, right? At the end of the day, the clinician knew what intervention that they were providing. And if they did have less equipoise and more of a bias in favor of that treatment, that could definitely come through in the way that they treat the patient or the outcomes. And patients, obviously, they knew that they weren't put in, they knew what group they were put into, whether it was thrust or non-thrust. And then also, one thing is the authors didn't stratify the patient sample based on duration of symptoms. Therefore, it's possible that patients who have acute neck pain or patients who have chronic neck pain could have different outcomes, right? The average duration of the pain was 60 something weeks. Well, there could have been a bunch of patients that had duration of pain 3 weeks, while other patients had duration of pain for 10 years. And that skewed the sample up to say that the average was 60 weeks. So we don't necessarily know. They didn't do an analysis of stratification between more acute and more persistent types of neck pain. So I'm going to go ahead and pop out of here. Hopefully you guys got a good idea of what they did in this study. And I'm going to stop screen sharing so we can maybe have a little bit of discussion about it. So what questions pop into you guys' minds after talking about the way that that study was designed, you know, some of the little things that I put in bold, some of the little caveats that we had?
I have a question.
Okay.
So I'm just trying to find where the quote is, but it said, due to the temporary nature of the treatment effects, it has been recommended that NTM or TM be combined with therapeutic exercise to attain longer term benefits. That like quote kind of rubbed me the wrong way. And I'm curious to hear your thoughts or other people's thoughts, because it just seems like kind of unsubstantiated that like just continuing to do it with exercise will lead to longer term benefits. I'm curious like if that quote stood out to you, but it just seems like not a strong statement for manual, just like throw it on with exercise.
Yeah, so I mean, I'll give you my perspective on that, and you got to remember that this is the world according to Jarod. This is just my opinion, right? It's my opinion that a lot of our clinical practice guidelines are written by people who have, you know, been in the profession for quite a while, and they have certain biases for certain treatment interventions, and they've gone through, you know, lots of education and that sort of stuff to learn manual therapy. And there may be a slight bias in favor of manual therapy with the way that some of our practice guidelines are written. And you can tell that when you look at it, when you look at the gradations of strength of recommendation of certain interventions, and then you actually look at the studies that are referenced, and you say, you know, I'm not sure that these things line up. So I think that it's a caveat. It's kind of a way to say, well, we don't want to have a total shitstorm and fight by saying that we do or don't want to recommend something. We're just going to say that, you know, if you do both of these things together, people seem to get more better without actually exploring the whole A versus A plus B, without exploring equipoise of the clinician in those type of studies, without exploring patient expectations of those interventions in the studies. And we also have to recognize that patient expectation comes from clinicians, right? So patients only expect things that clinicians have done to them in the past, or have done to their friends in the past, or they see in marketing, or they see in advertisements, or they see on the TV, right? So patient expectations and driving care based on patient expectations is actually a cycle that feeds into itself, because when you meet patient expectations, you actually perpetuate what their expectations are, which leads to you having to do it constantly to meet their expectations. So that's the world according to me. And I think that we're in a little bit of a cycle with that, because we're unwilling to break away from certain things that maybe could at least be called into question. That's not to say manual therapy doesn't do anything, right? If you whack your shin on the coffee table and you rub it, it feels better, right? You get a gating effect. But did I fix the trauma that I just caused to my shin? No, I just made it feel better for a little bit. And that's okay. Like, people like to feel better, and that's cool. But it's the narrative that we send along with that, and the expectations that we drive into people's minds with certain treatments that actually lead to some of the uphill battles that we have on changing our perspectives. I don't know if I answered you. Oh, sorry. Say that again.
I find it interesting that part of the argument, though, is Like, did you fix the trauma? Well, we don't fix shit. The body does what it does. We're just setting it up for it to do what it does. So when we already have the idea that we're fixing shit, we're in the rabbit hole chase to what fixes things rather than what's supporting the body to do what the body naturally does. And that's what we should really be kind of looking for.
Yeah, no, I agree 100%. We're not fixing anything when we put our hands on people. We're temporarily modulating symptoms while their body is healing themselves, or allowing them, you know, we can get into the whole discussion about opening up the window of opportunity and all that sort of stuff. And I don't know where I stand on that, because one day I stand and I'm like, oh yeah, that's a great idea. The next day I'm like, oh, is it really a great idea? Is it just, you know, perpetuating some of these things? I don't know. I don't have the right answer. But what I do know is that we don't give the body enough credit for the capacity to heal and adapt that it has. And we like to be the hero, and we like to put our hands on people and you know, make them feel better for a little while, you know, to quote Voltaire, while nature cures the disease or time cures the disease, right? And that's awfully cliche, but it's got a lot of truth behind it in a lot of circumstances. And I think that breaks down when we get to people who have persistent pain, because you can't modulate away persistent pain because it's been there and it's not going anywhere. So we have to break away from that and start looking at different things. And there's plenty of people that have bought yachts and mansions on, you know, modulating chronic pain for years and years and years while never getting people back to their real life. So, you know, I don't want to get too tangential, right? I know that this could evolve or devolve crazy fast. So I'm gonna shut up and let somebody else ask a question.
I'm interested to hear your thoughts on the deep neck flexor testing. We all do it clinically, right? Because we have some studies that show that deep neck flexors are weak in chronic neck pain type patients. But if you look at what we have to have change-wise, we need like 19 seconds, right? To show a realistic change. Yet most of the studies show somewhere between 30 and 45 seconds is the standard. So we got to have 50% change to show that we had a meaningful effect.
So I view, again, this is the world according to Jarod, I view the deep neck flexor examination and treatment approaches the exact same as transverse abdominis and core stability for low back pain. I think that those are findings that we have come across when we measure people with neck pain, and we say, oh man, you have neck pain and your deep neck flexor endurance is down. Your neck pain must be coming from your deep neck flexor reduction in endurance. And I think that it's probably more likely that if somebody has pain, it alters muscle function. They have changes in motor patterns. They have, you know, decrease in activity. They have pain, which makes them not want to push into that. They reduce, you know, the amount of movement and exercise that they have, which changes the cortical representation of how the body actually controls the neck and how you coordinate those muscles. And I think that that's a finding that is just concomitant with neck pain, and I don't think that it's a driver of neck pain. What's going on there? I don't know if we can mute Devarshi.
Yeah, so what guarantee that you can go down and get the...
Got it.
All right, cool. So from my perspective, you know, we've seen now with low back pain, like look at Ben Smith's systematic review. We see that targeting the transverse abdominis and motor control exercises and all this sort of stuff, yeah, it gets people better, but so does all this other stuff. So does general exercise, so does strengthening, so does course, you know, isometrics and all of this sort of stuff, and yoga and Pilates, they get people better. So I think in my mind, the deep neck flexor approach is literally the exact analog to the transverse abdominis situation in the low back. And I think that, yeah, doing deep neck flexor exercises, that's good. You're doing exercise to the neck. You're making somebody control it and move it in a way that they don't normally move it. You're getting long-term isometrics, which might create temporal summation, which might reduce pain. We're getting them to actually focus on an area that is painful and make them feel like they're doing something beneficial for it. We're getting the non-specific effects of just exercise in general. So I don't do deep neck flexor training or deep neck flexor testing in clinic just because I quit and people continued to get better without it. So I determined that it probably wasn't absolutely necessary, and the benefits that we saw from it were probably more complex explanations than what we were, applying to that, if that makes sense. And again, this is the world according to me. Like I am very likely to be super wrong, and I hope if I am wrong, cool. I'll update that when I get some new evidence.
This isn't really a question, Jared. Just something that I found interesting was the whole like using PAVMs from like a trying to reproduce pain standpoint rather than trying to like actually assess segmental mobility. I think that kind of frees you up as a clinician to just like, okay, it hurts here. We're going to apply a new stimulus here and not really care about if it's C5 or C6 or if it's hypomobile relative to another segment. So I just thought that was interesting.
Yeah, it's great because it frees you up away from the traditional concept of those accessory vertebral motions is that, well, we have pain because that particular facet joint or that uncovertebral joint is not moving well. Instead of saying, well, it hurts in this area and this seems to be the most sensitive area, and maybe there's some inflammation here, maybe there's some tissue sensitivity here, maybe that's referred hyperalgesia too, right? And that's something that I wanted to talk about a little bit. Is like, like people hurt on the inside of their shoulder blades, for instance, and like half of clinicians will say, that's a trigger point in your rhomboid, and the other half of clinicians will say, well, no, maybe that's referred hyperalgesia from something that's going on up the chain, and now that nociceptive pathway has been sensitized. And I don't have to figure out why somebody hurts when I do a passive accessory intervertebral motion, whatever. I hate that word. I hate that long ass acronym. Just say, I'm gonna apply a stimulus to that area, and if it recreates their pain, I'm cool with that, rather than I'm doing accessory stuff and all that.
Right. Yeah. I had a patient recently who had the same thing, just like numbness, tingling, like pain along like medial border of scapula. And I didn't really chalk it up too much, but I was talking to one of my coworkers who's like fellowship trained, and she's like, well, it could be a facet joint. And then it just got me on this long existential cervical neck crisis. So I'm glad I'm not alone in that.
Yeah. I mean, I think that we're crazy naive and over egotistical a lot of times when we think we can figure out exactly why somebody hurts. There are just so many factors that could make somebody have pain or be sensitive that we do know about but don't regularly think about, and B, don't even know enough yet to know that they're real things that could be playing a role, right? We have to recognize like what we don't even know yet that could be playing a role. And, so 5 years ago, I would have dropped needles all in that person's rhomboid and been like, I'm getting rid of that trigger point. Now I'm like, I'm not sure what to do.
Which I think more clinicians need to be like upfront about that. So I appreciate you doing that. Thank you.
Hey, Jared.
In the context of manual therapy. Oh, go ahead, Daniel. Go ahead. I saw you click in.
Yeah, no worries. So, Jared, thanks a lot for your presentation. Really, it was great. Well done. I had a question about the fact that some people would look at this paper and say, well, manual therapy does work, right? Because they didn't have a control. It was really either a manipulation or mobilization. And I just wanted to know, like in the group, I would have loved to see a control where maybe they just got some education, maybe some exercises, and then we could really see, how strong manual therapy is versus just proceed. I just wanted to know what your thoughts were around that. I think the other thing that might be interesting is talking about like maybe some of the work around another author that you kind of brought up, Dunning, on why his manual therapy skills seem to be so amazing out in Tennessee. And then my boys out here in Oregon can't do, do squat. So like, can you explain why he's fixing everybody? Back there, is it because he's dry needling with, electrical therapy? And, is it because he has an osteopathic certification? If you can just maybe go into that, maybe the control, like love to see a control on that. And then secondly, it's like, why did some people like be able to go crazy in Tennessee and can't go crazy in Boston with Zach or go crazy in Oregon with me, right? So just wanted to ask you that question.
Yeah, I mean, ideally, I would have loved to see a true control group, because we're really bad in the physical therapy world about doing a true control group. And a true control group does kind of suck sometimes, because you're telling a patient essentially that, well, you're just not going to get any treatment right now, and that sucks for you, right? But you can do like controls out of the community, just like ask people if they have neck pain, and then come, and they do, and then you come back like 6 weeks later and ask them how their neck pain is doing, right? So that's a way to do a control group that's not actually like pulling them into the clinic and saying, sorry, I'm not going to do anything. But yeah, in the perfect world, there would have been these two groups, a control group and and an exercise only group and a placebo group where maybe you did some like skin stretching, right? Because we have the concept, we have the belief that neck pain, that's joint driven, man. That's facet, that's, disc, whatever. What if I just target the skin? What if I just do like this really rhythmic, feels really good, skin stretchy, rubby type of technique that doesn't affect the joints at all? And then I get the same exact result. Then you can say, well, it doesn't have shit to do with the joints, doesn't have anything to do with the disc. Maybe it has to do with the skin, but you can start really like tearing down the traditional explanations for how the manual therapy works. So if you get a wild hair, man, like, do this study so I can review it. But as far as the particular author that we mentioned, I will say a lot of really good things about James Dunning, and the fact that he's brilliant. The dude is incredibly smart. He is charismatic, and he has done a lot for the physical therapy profession as far as, putting a lot of money towards protecting our ability to do high velocity thrust techniques if we want to, or if the patient comes to us for those things. He's done a lot for direct access in certain places as well. So Dunning has done a lot of really good things, and sometimes he gets crapped on, but I've met him personally, and he's a brilliant human being. But I also think that he is incredibly zealous in favor of manipulation and dry needling. And I have taken all of his manipulation courses and all of his dry needling courses. I will readily admit that. I went my first year out of school, I took all 5 of them. Like I was in, and I was drinking the Kool-Aid. I just couldn't bring myself to want to be called an osteopractor. And I think that he has a very robust following of people who are as zealous as him in favor of those interventions. And when you have people that are that incredibly invested, right? So that Equipoise scale, the -2 to +2, every single clinician that he uses in his research studies is a +3. They're like off the charts of maximum equipoise towards thrust manipulation. So you've got like, 10 clinicians, you got Tommy Peralt, and you got, James, and you've got, his whole group, and they're just like over here +3s. So the total volume in favor of manipulation is like a 30 rather than, a 6 that we saw in this study. And that shows through, right? When they do a research study and they have to pull a card that says, go do mobilization, dude, they look like a kid that just got their nose put in the corner, right? They're like kicking the dust, and they're all sad because they're not going to get to go in there and just like cavitate the hell out of somebody's neck and be the hero. So they have a totally different, and if you've watched James do manipulation, he is extremely charismatic and extremely theatric about the way that he does manipulation. It's a process, it's a ritual, it's a setup, it's hand placements, it's verbalization, it's rhythmicness, it's dancing with people. It's a really crazy good interaction with patients, and that comes through. that affects outcomes versus, well, I'm going to go do this mobilization and I'm going to have to do it for 30 seconds and it sucks, but whatever, I'll do it. Okay, did you get better? No, you didn't. All right, cool. Well, I guess manipulation's better, right? So there's a little bit of, and I'm dramatizing, but that's what those studies are going to look like because they're done in his clinics by people that have been trained by him. And that's going to show through in the way that a patient feels that they get treated. And when every other research group is getting equivocal outcomes and you yourself are the only person getting outcomes that are dramatically different, there is probably something about you that is different rather than every other clinician and every other research group sucking at manipulation, right? So that's my perspective on that.
Question.
You go ahead, Zach.
No, you go, Christopher.
Thanks, buddy. So, Jarod, you mentioned earlier on that patient comes in, they want leaching. You're very obviously not going to do that. Where do you have a hard line of what you're willing to do and not do for a patient in regards to their preference and kind of giving into, well, this is what the patient wants versus I will not do that?
Oh man, dude, black and white and hard lines are the quickest way to be wrong. So I don't have a hard line because I think that every patient that walks through the door might need me to interact with them a little bit differently. And if I know that somebody is, hanging on by a thread, but before they're going into a massive surgery that maybe they don't need, or before they're going to go down the road and get sucked into a 3 times a week for the rest of your life treatment plan, I'll swallow my pride and try to meet them where they're at a little bit more. And maybe I'll do that ultrasound, or maybe I'll do dry needling when I don't think that it's valuable or beneficial, but I am trying to build a relationship with that person and open their eyes to the fact that there are other factors that might be playing a role in why they're having pain, and try to, with permission from them gradually over time, educate them on alternatives to self-management strategies. And I recognize that could be perceived as the same level of being a hero as trying to use my hands to fix them, right? Well, I'm trying to be a hero because I'm trying to save them from the worst outcome. But when you look at the data on the amount of unnecessary surgeries and unnecessary opioid prescriptions and people that have spent their life fortunes getting their symptoms modulated for decades, I'm willing to swallow my pride and at least take that much of a risk to meet them where they're at, of course, if it's going to directly and immediately cause them tremendous amounts of harm or whatever it is, or if it's leaching and I'm like, I'm sorry, I don't have leeches, I can't do that. You're going to have to go find somebody else. But I think that it's probably a little bit different with every person that walks through my door. Some people, they are hardliners, right? There is no negotiation, and you have to kind of figure that out early on. And if you push too hard, you've lost that person. And if you push too hard and you've lost that person, you haven't provided them any good. But if you could provide them good by building a relationship and updating their perspective, then I think that it is up to you to do that, because that is within your scope of practice, and that is within critical thinking, and that is within the clinical reasoning paradigm of how you interact with that person and how you progress their treatment plan over time. I hope I didn't just talk in circles there.
I had a quick little question. First, I really enjoyed this paper. Just the idea of it being like a pragmatic really is a different spin and like a different sort of perspective than just a solid, really sanitary randomized control trial. And kind of on that note, going back to your limitations, when you were summing up the paper, I was curious, it didn't really say anything about the compliance with home exercise. And I didn't know if that's something that kind of stuck out to me, but I was just wondering kind of what your perspective was on that, or like maybe if from first treatment to discharge was too short to even really consider like the effects that might have.
So they didn't list that anywhere in the study. They didn't measure compliance. I mean, the average study duration or the average patient treatment duration was like 30 to 35 days. So I think that that's long enough that you could get some decent compliance data. I think they did a good job of limiting the amount of exercises that those patients had to do, right? They just had to do AROM and deep neck flexor training. That's 2 exercises. And, the data says that exercise adherence is significantly more if you don't go over 3 or especially 5 exercises. So I think that they designed it in a way that would at least maximize or help compliance, but they could have, maybe had the patient sign a contract because, hey, you are in a research study and we need you to do these home exercise plans and you need to be adherent to those. And there's a little bit of research on physically signing contracts, commitment contracts, actually increasing adherence to exercise programs, increasing adherence to weight loss programs and that sort of stuff. And this might sound stupid, but I have started with all of my patients at the end of an evaluation, and I give them a home exercise program. I look them in the eye and say, hey, this is, we're going to work on this together. This is a contract between me and you to get each other better. And I need you to do these exercises. And I ask them to shake my hand to enter into a verbal contract with me to improve adherence. And I have no research on whether or not that's valuable. That's just me having a little bit of a quirk and trying a little bit something different, because I live in the South, I live in Texas. So like your handshake and your word is everything, right? So I'm trying to use that for the culture that I live in to improve the adherence to the programs that I give. But it would have been interesting to see their compliance or adherence data.
How's it going? I have a thought I'd like to share. So this is the pragmatic design is accounting for some shared decision making. So we know that there was some communication going on between the clinician and the patient throughout the process. And I thought it would have been interesting if they did some research on the patient preference in the study, like found out what, at some point or at the end, I don't know where it would be best, but what was their preference and how does that affect the outcomes?
Yeah, that would have been great to see, but that study has been done before a couple of times. And whether a patient's, when a patient gets an intervention that they prefer matched to them, they tend to have superior results or superior outcomes when they receive the intervention that they themselves have a preference for. So for instance, if I go in and like, let's say I wake up, with a crick in my neck and I'm going to go to the local chiropractor and I want my neck popped. I want that cricked out of my neck. And I don't get it. And they just like gently like rub on my neck and do a little bit of gentle pressy guessies, then I'm probably not going to be super satisfied. I'm going to be upset. And I'm already, even if they stimulated, all sorts of nerve endings and all that jazz, I'm already like, man, this is garbage. I'm not going back there. I didn't get what I came in for. So my outcome is crap, even though what they did could have actually made me feel better.
Thank you.
Yeah, I'll go ahead, Zach.
Sorry. Well, first off, thank you, Jarod. We were kind of chatting in the back. That was super comprehensive review of that. So much appreciated, especially since I didn't have time to read it. But, one of my questions for you and posing it to everyone is sort of this, like, at the end of the day, understanding what we found from this and similar studies along these lines, like, this is the ultimate existential question as a therapist, is like, where the hell do we stand in terms of what the sort of shared consensus is with what we're doing? Because like also having had attended James Dunning's, dry needling courses 5 years ago, I saw firsthand like how charismatic and how zealous he was and his charming British accent and how like patients probably eat that shit up. And it's like, the same way you were talking about how like you're the hero now with saving the day with self-management, like that is sort of the idea now, is we are able to, knowing what we do about contextual factors and how our ability to be charismatic and, show confidence and, belief in our treatment approach, like I feel like we can leverage that for good, because at the end of the day, we are always going to be leveraging some of that, right? And we might as well maximize it for the better. And so this is the hard thing. You said something before that's like, it's very reasonable for patients to want short-term relief from some of these things. And that's an area that I've thought hard on, where I, 2.5 years ago, when I was peak, PNE Zach, making it rain RCTs, if anyone dared ask for any sort of manual therapy or ultrasounds, definitely changed my stance on that a little bit, where I am much more willing to meet people with where they're at. But I feel like that's ultimately the really hard question for all of us to reflect on, is like, how do we continue to pour so much money into some of these manual therapy researches, and like, what are we ultimately going to end up doing when we know that like exercise and self-management probably has pretty equivocal long-term outcomes and potentially less healthcare utilization? Because I feel like we've been having this manual therapy talk now, at least for the past few years, where we've been kind of building on some of these consensuses or takeaways. But I don't know, it's really interesting food for thought in terms of how, when do we kind of step in with these patients and start to, like you said, not reinforce and perpetuate this cycle where now we're creating these societal beliefs that this is what they want, while balancing, meeting them where they're at. It's really just, that's still gives me grief. And it's still just a really hard thing that I personally struggle with. Sorry, I know that was fucking brain vomit.
No, I mean, I definitely know exactly where you're coming from, because it's the thought process that I have all the time, every day, every week, for the last months and years. And kind of where I'm at these days is, first of all, every person that's on this call right now is already walking in that uncomfortable zone of thinking about this. And that is an enormous step in a positive direction, because 10 years ago, this wasn't happening. Everybody was just getting like, the hardcore, manual therapy, backslapping, like polo conference wearing, like fixing the world hand skills. And now, and that not questioning and not reflecting on and not having thoughts about the way that you're thinking and just going hardcore in that direction is probably not safe, right? It's probably not, I won't say not safe, but probably not a good idea. The fact that everybody on this call is reflecting on that and asking hard questions and feeling uncomfortable, that automatically means that the needle is shifting in the right direction. Just the sheer fact that this is occurring, right? That is brilliant and beautiful. And, you mentioned something that I probably can't say enough. I would scream it from the top of the Empire State Building if everybody in the freaking state of New York could hear me. And that would be that we need to focus more on public health, and we need to focus more on reducing overutilization. And if you want to talk about where PTs can have the value in the healthcare system, or chiropractors, or all of us, like, non-surgical, non-medication prescribing providers, it's public health. And it is incredibly valuable to provide treatments that have secondary benefits of health and increased bone density and reduced insulin sensitivity and improved sleep health and improved, cognition and improved lifespan. And that's what exercise does. And that's what educating people on a lifestyle and getting them involved in a lifestyle that it encompasses those things does. And, manual therapy, it can make you feel better. That's great. Again, that's fine, but it doesn't reduce your insulin sensitivity. Manual therapy doesn't build muscle. Manual therapy doesn't increase basal metabolic rate. Manual therapy doesn't do all of these things that we know that exercise does, right? It doesn't have anti-inflammatory effects from the proliferation of telomeres on your DNA and reduce, frickin' free radicals. No, it doesn't do that, but exercise does. So that's why I'm biased in favor of it, because it's a way to get to the same end as maybe modulating somebody's symptoms, but with phenomenal secondary benefits, right? And we could even say that those are the primary benefits, and the reduction in pain is the secondary. So my mind is zooming out of just helping people feel better if they get hurt, or just helping somebody rehab from a surgery, to how can we change the way that society interacts with and views exercise and health, and why they're having pain, and influence the choices that they make, which I mean, they're opioids or they're too many surgeries. I mean, we've had to create ICD-10 codes on failed back surgery syndrome because so many people go down the pathway of having unnecessary spinal fusions, which leads to more trauma and sensitivity, which leads to another spinal fusion, which leads to more trauma and sensitivity, which leads to more disability. And I mean, we're arguing over, I won't say we're arguing, we're having a really good discussion. And the profession oftentimes is arguing about, you know, the minute little differences of like, if this manual therapy works better or that manual therapy works better, is it like a 0.5 on the NRPS versus a 1.5? Like, that's okay. But if you're having to argue over like a 0.5, which isn't even statistically significant and definitely not clinically significant, how valuable is that really? I think that we can zoom out a little bit and have an unimaginable effect on the whole healthcare system. And that's me up on my soapbox, and that's me like on the ivory tower and like looking like 30 years down the road. But that's just my mindset.
I have a case, and maybe it'll help. And I love your approach, Jarod. Just know that I'm behind that 100% too. At Fox, I'm doing a bunch of work around that. But I do mentorship on Fridays in our community clinic. And I got an email from an alumni who was having some issues with a DO. And the DO had a back issue and wanted me to take a gander at it at our community clinic. And so the DO comes into our clinic and he has a herniated disc, or what looks like a herniated disc. And he's a retired DO. He knows how to do OMT, which is not orthopedic, but osteopathic manual therapy. And so he knows, he's well drilled in it. And he comes in and his belief is that his SIJ is out. It's his complete belief. But the interesting thing is that extension makes him feel better. Like if he extends like all day, he feels great. It's when he sits when he's having the problem. And what caused the mechanism of injury was when he was, you know, those big flagstones, he was maneuvering about 30 of them up and down an incline all day. And then he started noticing his back got a little achy. And so he comes in and he tells me about all these problems, and he's asking me to basically do a manipulation on him. Like he's saying, I need a manip. And I don't know if you've ever had cases like that where their expectation is so strong and they've seen other clinicians. They're like, this is what I need. Zach, give me an SIJ gap, or like, give me that thoracic spine manip and make me better. And he was asking me that. And he saw another physical therapist and they gave him the CPG rite of acts. They're like, hell no, you don't need that. And then he talked to, you know, another PT. Nope, you don't need that. And he's like, what the hell's going on with PT? He's like, are you guys like manual therapists, or like what's going on, right? So it was really funny to hear his perspective, because he's like, I just see it as a non-pharmaceutical issue. Like, you guys are not giving medications, you're putting hands on patients. All the PTs I talk to are saying like, heck no, don't touch, not gonna touch me. So I'm like, okay, I'm gonna touch you. So I do the clustering of tests for SIJ, right? Just the clusters of them. And he's negative for every single one. So I go through each SIJ special test, right? And right now I have like 4 residents who are with me, or, like mentors and mentorship program. They're looking at me, they're super ass confused because I'm getting like super mechanical. Like I've got the goniometer, I have the inclinometer out now. I'm just like measuring everything. Like I'm gonna out finesse this dude like all day. He's gonna get tired of me. So I'm like, it's 0.83 or whatever. And so my students are laughing. And so they're doing this and he's like, right? So I do this, it's like 10 minutes. This is the funny story. He gets up and he goes, you're right. I don't think it's my SIJ. And I said, well, how did you get to that conclusion? He goes, because your testing was amazing. You tested my ligaments. You tested my, I even did the Gillette's test, right? I mean, when was the last time I did a Gillette's test? I don't know. 20 years ago, it's like, and then my student goes to me later on, they're like, the SIJ doesn't really move that much. I said, SIJ can have some issues if these cluster testings are positive, right? But he was negative for every single one. His conclusion was, you could probably give me a manipulation. I think I'm just looking for something to make me feel better. So we had that conversation. So at that moment, he fit in like a clinical practice rule, which isn't very great, as you guys know. And so I actually gave him the manipulation. I did. So then I gave him the manipulation at that point, and he was just thrilled that it wasn't his SIJ. we found a hypomobile point or whatever we thought was hypomobile to him. And then what happened was he was so biased, he was so thankful, he decided that he wanted to check his own range of motion again for me. And then of course he got like 10 more degrees of everything. And my students looked at me and they're like, we're amazed, number one. Number two, do you see the effort he was putting into it? I mean, he was grimacing, like, oh! He was just trying to give me all of the range known to God, you know, like, I'm going to give you everything because you're my guy. And so the second week he comes back, I didn't give him a second visit. He called back and he says, I want a second visit. So he calls to just talk to me. This is what he says to me. He goes, I had pain relief for 5 hours, but then it wore off. And I said, yeah, that's about right. And he goes, but you know what? I'm so grateful that it's not my SIJ. And I said, so what else do you want? He goes, oh, I'm going to do all the trunk stabilization exercises you told me. I just wanted to thank you again. See you later. Just took off. This is true. This has happened like 2 weeks ago. But my students asked me, what would have happened if I didn't do the SIJ clearing testing? Right? And just had a talk with him around it. And I said, he would probably think I'm not skilled. But the thing is that we're skilled. Like, I got game. You guys got game. Like, we're skilled. I didn't give him the minute because he didn't need the SIJ minute because I didn't know, and we knew it wasn't the problem, but we cleared out the joint below, right? We cleared out the joint for him. And that made all of the difference. So sometimes it's not about the minute. It's about like, how much can you ball up on someone before you shoot the hoop, right? I mean, sometimes they don't even need to take the shot. They just could just tell by the way you're warming up that like, oh, snaps. You know, it's like, these guys are not fooling around today. You know, it's like you bring in the heat and then they're like, whatever you want, right, Jarod? I mean, you probably see that. And it's like, I think that's what I'm teaching the students. It's like, understand how to think things through before you think about the manip. The manip is the last thing, dude. It's like, don't even think about it. It's like, what's your clinical what's your clinical rules? What's your clinical decision-making? That's what I want to know, man. Because then if you can do the manip, great. If you can't and you want to exercise them, great. Like, we're good, man. We're good. We're exactly where we need to be. But if you're thinking about the treatment already, that's just like, I don't know, man. It's like you're trying to rush the relationship. Don't do that. So wait.
Are you telling me that you took the time to actually recognize the importance of the values that your patient had and change your approach and your plan of care and your thought process to match the patient that was sitting in front of you to maximize your outcomes, even though you knew that maybe what they wanted isn't exactly what they needed?
Yeah, I guess that's I don't know, man. I'm not wearing my doctors right now. I'm wearing my hickey, so I don't know. I'm not in my clinic attire, but yeah, absolutely. I mean,
no, dude, that's awesome. That's beautiful. And like, if we could take that story, that thought process, and broadcast it out, that's where our mind needs to be. I can't tell you how many freaking supine descent and Weber Barstow tests and Gillette tests and stuff that I've done for people that thought that their pelvis was out, and they really just needed to hear, nah, dude, it's not out. And that's the yes and approach, right? Yes, I will look at that, or yes, I think that maybe that is playing an issue. And I think this also might be playing an issue for you as well. And let's connect those dots so you start to look at things a little bit different than, you know, the bias that they come in with.
Yeah.
You guys have any other questions? I'm about to have to jump off. Like I said, there's a wine tasting waiting on me right now. Saturday.
I don't think anyone can top what Daniel just said, unless Zach, I saw you got unmuted. What do you have?
No, that was awesome. Thank you, Jarod.
Thank you, Jarod.
If people want to nerd out for a little bit, I'm down. This conversation is just super interesting. So if other people want to chill for another like 10 or 15, but Jarod, go get your wine on, baby. Thank you.
Thank you, Jarod.
Guys. No, thank you guys for having me on here, and thanks for the discussion. This is great. Like, this is what I freaking love. And to see this in the profession now, like I said, this stuff wasn't around when I was in school or when I came out. So it is just game changing.
Jarod, we're looking forward to seeing your work with the public health part, man. That sounds real great, sexy, all those good things, man, that you're just busting out. So I can't wait for your work to come out. Hopefully you're going to be publishing and lecturing more about it, man. We need that in our profession. I want you to know that. So glad that I got to meet you. hopefully we can hook up at CSM or some other place too in the future, man.
Yeah, that would be great. I appreciate your perspectives here, man. They're super valuable.
No worries, man. I appreciated you.
All right, Jared, enjoy your little wine day. And as you said, Zach, anyone who wants to stay on the call, we'll chill for another like 15 minutes, party it up.
All right, later, guys.
Thanks, Jared. Oh, yeah.
Yeah, I was actually wondering other people's thoughts about I know we sort of diverged a little bit, but the actual equipoise part. So I guess what worries me is with a study like that, the results were that there was a correlation between their equipoise towards or against utilizing manual therapy. So if the results showed that, whether or not it was the best study ever without or with a control group or whatever, I guess, does that mean most people are going to take that? Like Dan, you were saying, most people say like, okay, yeah, the manual therapy works. Or is it, how hopeful would you guys be that people would take that and actually use it to be like, oh, maybe I should reflect a little bit more about where it's basically a fancier form of bias, but like where my bias lies prior to implementing these interventions. I think that's the one thing that I'm like, that's where I think our group may be a little bit more biased in, okay, yeah, this prompts me to reflect a little bit more. I just don't think the larger population of our peers and colleagues would necessarily have that takeaway. They may have the takeaway that you were alluding to before of like, yeah, this is why manual therapy works. Duh, that's why I do it. Just any other thoughts on that?
One, I don't think many of the other people are probably reading this article.
Yeah.
And those that are reading for confirmational bias, typically, right? So people are typically scanning for what they're looking for in the literature to support what they want, rather than looking at a broad scope of what's in the literature to get a good idea of what's there. To me, what this tells you and what Equipoise really is whatever you're bringing to the patient matters, right? And to me, that's a good thing, because whether you believe in this or you don't believe in this, how you're presenting that to the patient and how your kind of your controls and your contextuals matter. Context always matters. And so their belief systems and your belief systems, and merging those as close as you can, will lead to a better outcome. And so I think we all have to be meeting them and where we are coming from and merging those together to get that better outcome. Daniel, in his story, knew where he wanted to be, but he was going to meet the guy and bring them closer together. He still did what the guy wanted, but he had to prove and show what he knew, right? So if we get that buy-in, this guy has a DO, so we have to show a little bit level of skill set before we get that buy-in. But bringing our full selves to that allows us to get a better outcome with that individual, but it's meeting them with what we're fully bringing. And I think that's something to be aware of, is where our biases are, but that's part of who we're bringing at that point in time, because your biases are going to change, or your thought processes may change as the literature changes, as other things changes, but knowing what you're bringing to that table is important. And I think that's what this group really does good, is thinking about what am I really bringing to the table? What are my belief sets and what are my skill sets that I'm bringing to have that outcome?
I like that. That's a more positive outlook. Thank you, Paul.
Also, I feel like I'm missing something, because right when the discussion starts, it says patients were not more likely to have a successful outcome if they were allocated to a treatment that the clinician favored. Is that what you guys got, or am I missing?
Yeah, that's what I picked up.
So isn't that kind of opposite of what Jared said then?
I believe what he said was when they controlled for, they didn't do that. But when they looked at it, there was a small global effect. But then when they controlled for where that Equipoise was, it led to no effect, no overall effect in the difference between those.
Yeah, the quote I had was, this suggests that whether or not the clinician's preferred intervention was matched with the patient's group, the outcome was not altered.
I think.
Dun, dun, dun.
I'm also wondering if it was more so how although I'd have to think back to his presentation, but I'm wondering if part of it is also just how the conversation evolved. Like they have gotten away from specific results.
Well, we kept mentioning the other papers where there was
Right.
differences. Yeah.
I also thought it was, so they talk about like global equipoise and then also like the individual. And so I was just wondering, like, if you go down to the tables there at the end, like it sort of has like the characteristics of all the different clinicians. And so they have, I guess, that the rating number is their global, but then were they reassessing these like on an individual patient basis, like based on what each patient presented with? I kind of had a little question about that.
No.
Yeah, that's great question. And I guess I think that's the hard thing about a lot of this research. And that's been a topic of deep interest of mine over the past few years, is understanding more about meaning response and contextual factors and how that influences outcomes from both clinician and patient perspective. And I think that's just like a really, really, really hard thing to control for in the case of a study, because there just is so much of that inherent in a clinical scenario, whether researching or not. And I don't know, it's just like, I think back to, people like James Dunning, and it's just like, he's so hardcore on like, you need to get the audible pop, and he's so confident with it, and his theatrics are so on point that I imagine his outcomes are probably pretty good. So like, I'm wondering if anyone else in here is familiar with some of the research on, contextual factors in outcomes and how much that does leverage. Because it seems like in this paper, there wasn't a significant finding with the equipoise one way or the other, right? Is that what we're kind of landing on at this point? Is that with this paper, there wasn't a massive effect for that?
It wasn't a massive effect, but they controlled for it. They measured for it so that they have readily, they could shade a little bit towards the side, because I think 6 of the people were positive for the manip or whatever, and then they had 2 here and 2 there or whatever it was. So they were balanced out, and so they were able to control for that a little bit, looking for it. It does show, if his summary was correct, because I don't remember exactly where they said that the global preference was more towards, other than just the summary of whose peoples were there. But I go back to, we're not petri dishes, right? So this is a hard thing in research to be able to do, because no matter how well blinded what it is, who that person is, both patient and whoever's delivering the service in the service delivery model of research, their wording, their mannerisms. It talks about hand placement, all those other contextuals, how well you cradle a patient, if whether or not they feel, that you have good control or not. All of those kind of things matter into what it is. And with Dunning, right? So if he doesn't nip and he doesn't get an audible, okay, he does it again. There, we got it. What did we get? We got an audible. But to the patient, it may be, oh, now I'm back in alignment, right? All those other things. So that belief system, and it feeds into that kind of stuff, right? So all those things matter, and they're not able to contextualize that or tell you what's going on in the literature in and of itself. So we're always in the dark on some of those things that really, really matter, to the degree of which I know a little bit about from the literature as far as what that is. I mean, there is literature that shows, even with just the quote unquote placebo effect, there's biophysical changes in the brain. Serotonin, dopamine, other things are responding in the brain. So are we looking at those things? Are we looking at blood flow changes for all those contextuals? I'm not familiar enough to know, do we have any of those other studies?
Was it Logan who originally asked about the interaction effect, the specific sentence?
I just brought up the point in the discussion. Yeah, I think.
Okay, sorry, my short-term memory is horrible, so I have to ask. I read again, it's a statistical statement. I can describe it if people are interested, but essentially it's the difference between an interaction effect and a main effect when you run an ANOVA or an ANCOVA, right? So let's say, brief aside, let's say we're studying steaks. I like steaks. Let's say we're studying steaks and how good steaks taste. We can look at different factors of the steak. We can look at rareness of the steak and salt of the steak, right? And the question is, does the rareness of the steak affect how good it tastes? Another question we can ask is, does the amount of salt on the steak affect how good it tastes? The third question we can ask is there an interaction between the rareness and the salt that affect how good the steak tastes, right? In other words, can we consider rareness and salt independently? A significant interaction effect suggests that we can't consider them independently, right? So, sorry, Paul. But what they're saying here is that there was no, the clinician preference did not interact with group assignment and any other analyses. That just means that when they ran their model, that preference, which was rareness in our example, did not have any interaction effects with quote unquote salt in their models, which would have been other things such as number of visits, duration of care, et cetera, et cetera. So it's more of a statistical phenomenon than anything. Yeah, sorry to nerd out in the numbers there. But,
no, thank you for that explanation.
Yeah, of course.
So what's the takeaway there? That am I the only one who's lost? So, all right, Joseph, are you saying, like, a big picture sentence, was the clinical equipoise impacted the patient outcomes, or did it not?
It says that they can be considered independently. So it's like asking, did rareness affect the taste of the steak or not? And short story made long, basically, yes, it did. And we can consider rareness independently of salt. That's the significance that they are attributing to that statement. Does that clear it up at all?
Definitely
Kinda,
not.
maybe, no. Okay, gotcha. Yeah, it's the stats part of it. Basically, they're trying to figure out, what, like, we have an outcome, and like, what explains that outcome, and are the levels of explanation related or not? And they're just saying that, as it turns out, no, they're not related. So we can consider these things as separate.
That helps. Thank you so much. What's your background? This is great.
I'm currently a PhD student. This is
yeah. Where are you a PhD student?
Penn State.
Dope. Wow. Thank you for
We are
enlivening me to stats. Stats is really hard.
All right. It's been real. My brain's starting to get fried. Joe, thank you for that, though. That did actually help towards the end, that last sentence.
Miss you, Joe.
And we miss you. Go IC. Thank you, Chris, for organizing this.
No problem. Every week. I'm a machine. So yeah, thank you all for joining the party. This is recorded somehow. It says it's iCloud. I've never tried it on the iCloud. I don't know if it's just going to disappear. But yeah, you all enjoy the rest of your Saturday. Yeah, have a good rest of your weekend.
Bye, everyone. Bye, guys. Thank you.